Good evening, everyone. So, what I plan to take or what I plan to talk today is how to handle hypoxia in a ventilated chair. So, what I really plan to do in the next 20 to 30 minutes or so is to discuss the causes and management of of hypoxia in ventilated children using some real life clinical scenarios. So, let me share the screen. So that's a topic, that is handling hypoxia in a ventilated child. So now we need to know that hypoxia in a ventilated child can happen due to various reasons. And as the reasons are varied, so are the solutions. So three common clinical situations when we encounter hypoxia is one is soon after intubation. A child might have been okay, or okay in the sense the saturation might have been relatively better pre-intubation, and suddenly the child deteriorates post-intubation. So why does it happen? Or sometimes you have a child who suddenly deteriorated, suddenly went in for a hypoxia on a ventilator, previously was looking relatively stable. Or you have another subset of patients who undergo progressive desaturation. That means every day or every after a few hours, you feel that the FiO2 requirements are increasing and you keep on increasing the ventilator settings. So now let us see what are the causes. So first is soon after intubation. So we'll start with the first case scenario itself. So here you can see an X-ray of an 8-year-old child who's admitted with severe pneumonia. And because the child was hypoxic at admission, the child was offered NIV, and presently the child is on NIV BiPAP with an FiO2 of 70% and he's saturating 94%. But the problem here was when the child was initially connected to ventilator, he was just requiring 50% FiO2, but now the FiO2 requirement has gone up. And similarly, his work of breathing has not settled. It is progressively worsening and tachycardia has also developed. So all the indications why you should consider a intubation in this child. So hence the child was intubated. But unfortunately, you can see here post-intubation, the FiO2 is 100%. So you remember on NIV, his FiO2 was only 70%. Now he's on 100% FiO2, but unfortunately, the saturation is only 61. So now what are the causes of a child desaturating soon after intubation? So here you should know that two common causes are inadequate pre-oxygenation, or if you're dealing with a child with an ARDS or severe pneumonia, then loss of PEEP during intubation. Because till then, if the patient was on NIV, you were providing him with PEEP, you are providing it with PIP, his alveoli were all distended and he was oxygenating well. And suddenly you remove, you bag, you intubate, you've lost all the PEEP, and that may also lead on to a hypoxia post intubation. So it's very, very important that in order to avoid these, the first and foremost is do a pre-oxygenation with a device that gives you 100% FiO2. So here there is something that we need to understand. When we say pre-oxygenation, it does not mean that we want to achieve a SpO2 of 100%. That is what often you think, that you want an SpO2 of 100%. No. Here you want to give oxygen with a device that gives you close to 100% FiO2, so that the aim is to denitrogenation of the lungs. That is, as you all know, in the normal room air, you would have around 78 to 79% nitrogen, and you want to remove that nitrogen and fill it up with complete oxygen so that there is a reservoir of oxygen inside your alveoli and critical desaturation does not happen during the period of apnea. We also need to know that when the saturation reaches 90%, then after that, every minute there would be a very rapid decline in saturation. You would have seen that. Initially, the saturation holds on, then once it starts declining, it just seems to be precipitously falling down. And that is because, if you remember the oxygen hemoglobin dissociation curve, that means you have, from the plateau, you have come to the steep part. Okay, so this much you understood, that you are trying to give 100% oxygen so that the nitrogen is washed out and your alveoli is filled up with oxygen. But I would say, now what is the importance of this pre-oxygenation? That can be beautifully depicted in these two images shared by Dr. Pramida. Here, what you see here really is that this was a image screenshots taken for a patient who was undergoing apnea test because of brain death, because we were considering organ transplant from the baby. So here what you see, if you closely observe, you'll realize that the patient, both these screenshots, the heart rate and saturations are same. But in the first one, you have a EtCO2 of 44, whereas in the second one, you have an EtCO2 of 67. And the first one was taken at 321 and the second one at 331. That means 2 shots at 10 minutes interval, but the saturation, the heart rate remains the same. So just imagine this baby has been disconnected from the ventilator and just been provided with free flow oxygen. And in spite of 10 minutes gap, there is no fall in saturation. So this is exactly what you should remember. That is, you can get a safe apnea time of 8 minutes or more if you are pre-oxygenating with 100% oxygen. Whereas if you're not pre-oxygenating, you may get a safe apnea time of just 1 minute. So that is the difference. So never forget doing a pre-oxygenation, and that too with a device which gives you 100% FiO2. Now, but you should also remember that if you're talking about pre-oxygenation of a child with severe pneumonia or ARDS, you will not get, in fact, such long an apnea time. So such a long apnea time is mainly when you are ventilating a normal lung, say an unconscious child, say trauma patients, encephalitis patients, seizure status patients. They are the ones who are going to get such long apnea time. But others will also get a shorter but reasonably good apnea time for a safe intubation. So that is the first thing that you need to remember. The second is, if by any chance your child is already on an NIV, especially on a nasal NIV, be it a pillow, a mask, or a CPAP mask, it's always better that you allow it to be there. That is, let it be there, and then you intubate. What you need to do is NIV, increase the oxygen FiO2 in the NIV to 100%. From the ST or the BiPAP mode, change it to PCV mode so that while intubating, even when the patient's efforts are less, the patient gets a good breath. So that, and doing this greatly increases the patient safety. At the same time, also ensures that the loss of PEEP during intubation is minimum, especially for a child with pneumonia. So, and if you're having a oronasal mask, you can think of shifting on to a nasal mask and then intubating also, especially in cases of bad ARDS. Okay. So now, so that was one way of decreasing the chance of hypoxia. Now, the second is, while you're intubating, do apneic oxygenation. What do you mean by apneic oxygenation? Apneic oxygenation means that while you're intubating, if the patient is not on an NIV, then provide him with a nasal prongs with a high flow oxygen. So that ideal would be an HFNC, even an ordinary prongs. If you keep 6 to 8 liters for the time of intubation, it is well and good. Now, what do you mean by apneic oxygenation? Just by putting a nasal prongs to the to the nose, how is it going to provide oxygenation to a baby who is not breathing? Now, here there is an important concept you need to understand. When your lung is full of oxygen, and even when you are not breathing, the oxygen from the alveoli enters the blood. That's the exact reason why, in spite of 10-minute apnea time, you saw that the SpO2 had not fallen. So in adults, they say that around 250 to 500 ml per minute of oxygen gets absorbed from the alveoli, even when the patient is not breathing. Whereas when a patient is not breathing, it's only 8 to 10 ml per minute of carbon dioxide that moves into the alveoli. So what will it happen as a result of which? Because of too much of oxygen is getting absorbed, but too little carbon dioxide is coming out, it will create a subatmospheric alveolar pressure, generating a mass flow of gas from the pharynx to the alveoli. And this is how the apneic oxygenation works. And in healthy adults, they say a PaO2 of more than 100 can be maintained even for 100 minutes without a single breath if you're giving a good apneic oxygenation. So now you understood how to provide an apneic oxygenation, that is with a nasal catheter at a higher flow rate. Okay, now so for our patient, we have done both these, but still the patient soon after intubation is hypoxic. So one of the common reason may be a malpositioned tube, that is the tube might have not maybe high up in your throat, or instead of going into the trachea, it may have landed up in the esophagus. So it is important that after you have intubated, you do the 5-point auscultation. And on small baby, the axillary auscultations are definitely mandatory. And another point I would like to say is that many times you will say, Madam, I saw the fogging. See, the fogging is there. So definitely my patient's ET tube is inside the trachea. No. You can have fogging even with the esophageal intubation. That especially happens if you have bagged the child prior to intubation, or the child was on an NIV with high pressure and already your stomach is full of air. You still can find a fogging there. So fogging is not an ultimate answer that you are inside the trachea. So always auscultate the epigastrium. So if the sounds in the stomach is more clearer than the sounds in the chest, or is of the same intensity, it's high probability that you have gone into the esophagus. So that is one thing. The next is when you have intubated and you find that your ventilator settings are high than expected. So I'm talking about a normal lung ventilation. So this is a child with GBS who's ventilated and is hypoxic soon after intubation. Why should a GBS be hypoxic? You're expecting a normal lung. So here what has happened? Your tube has gone to the right bronchus, because of which the whole of the left has become collapsed. And rarely you may have the tube going into the left bronchus and making the right collapse. So whenever you see a whole lung white, always remember that it's high possibility, especially without a mediastinal shift, the high possibility that the tube has gone to one bronchus, leading on to the collapse of the opposite lung. And always remember, going into right is more common because the right bronchus is straighter. So whenever you find that your patient is requiring a higher settings, always auscultate and see that maybe when you are fixing the tube, your tube might have gone slightly in. So you may require to reposition it. And of course, portable X-rays tell you definitely what is wrong. So that is another way of preventing oxygenation or managing hypoxia. Now, coming to our child. So what happened to our child was none of these were the causes for hypoxia happening soon after intubation. It was when the X-ray was taken. In fact, looking at the first X-ray, when the child became hypoxic, we thought, oh, pleural effusion has increased, should we have tapped? But when you took the X-ray, you realize that the pneumonia has badly progressed and you can see almost complete whiteout pneumonia. So this can also happen in an already ventilated child when you have progressively falling saturations. That means increasing requirement of FiO2. The classical reason is you have a progressive pneumonia. So what would you do when the pneumonia itself is progressing and causing hypoxia? So we are discussing here hypoxia management in a patient with severe pneumonia or ARDS. So here, so first thing usually everyone says is that I want to increase the FiO2. So I would say, please don't do that. That is the last thing that you need to do. The second one is PEEP. We all know many a times students say that when I am bagging, I am getting a very good saturation. But the moment I connect the patient to the ventilator, the saturation falls. Why does it happen? It happens because when you're bagging, you do not know what pressure you are using. So you're using a higher pressure, generating a higher tidal volume, leading on to a better oxygenation. But as far as a child with ARDS is considered, increasing the PEEP is never a solution. When you increase the PEEP, you will definitely get a better oxygenation, but that happiness is momentary. For that day, for that shift, you may be happy, but you will find the child next day deteriorating because a high PEEP will damage your lung. In fact, worser the lung, smaller should be your tidal volume. We classically say 6 ml per kg. If it's a normal lung, if it's just a pneumonia, you can even afford to put an 8 ml per kg. But if your ARDS is worsening, you need to come back to even to 4 ml per kg. So that is an important point. Never try to increase PEEP to increase oxygenation. Then the third one is very important. That is increasing the PEEP or finding the optimum PEEP. We'll come to that shortly. Then another way of improving oxygenation is increasing the inspiratory time. You might have read in books that they would say that you can do 1:1 ventilation or you can do inverse ratio ventilation. But remember, for you to do inverse ratio ventilation or 1:1 ventilation, you have to have complete control on the breath rate too, because you have to ensure that expiration is complete. Without expiration being complete, you cannot just blindly increase the inspiratory time. So as far as possible, keep the longest possible inspiratory time in so that you have the highest mean airway pressure to give you a better oxygenation. Remember, increasing the PEEP, increasing the PEEP, increasing the inspiratory time all causes increase in mean airway pressure. So that is, if someone asks you, give me one answer, how are you going to increase the oxygenation? Your answer should be, I would be increasing it by increasing the MAP, and MAP would be increased by PEEP, PEEP, or inspiratory time. So now coming to the PEEP. So how do you set the PEEP? In fact, PEEP is not a number. You can call it as a PEEP. You can say the pressure support above the PEEP, or you can call it as the delta P, whatever you name it, the pressure which gives you the tidal volume. So we here are discussing only of pressure control ventilation because that is what we commonly use in children. So initially you keep a pressure support above PEEP, which gives you a tidal volume of 8 ml per kg, but within 2 hours, bring it down to 6 ml per kg, because you always want something 6 or below, you don't want higher. And then remember, worser the lung, this lower the tidal volume. If the lung is not that bad, if you're requiring very minimal settings, you may even opt for a higher, but usually it is 6 or below. And the minimum tidal volume is 4 ml per kg. So why do you say that use small tidal volume, use 6 ml per kg, bad lung, use 4 ml per kg? You need to understand that in an ARDS, it's never a uniform involvement. That is the main difference from a hyaline membrane disease or RDS of newborn and an ARDS of a pediatric patient. So here it is, you have a heterogeneous involvement. You will have a normal lung, you will have partially collapsed alveoli, and you will have completely collapsed alveoli. So if you are using a high normal tidal volume, so you are trying to generate the tidal volume from the normal part of lung. You're making the small amount of normal lung that is left behind to work too much, to get hyperinflated. So that is the exact reason. In order to protect this normal lung, you want to do a small tidal volume ventilation. So the main aims are, as I already said, to prevent overinflation of the normal alveoli, you would use a low tidal volume. Similarly, in order to prevent exhalational alveolar collapse, when the alveoli are damaged in ARDS, the surfactant is reduced and the alveoli is always ready to get collapsed because there is very little surfactant there. So every time during inspiration, the alveoli will open, and during expiration, it will collapse. And when this happens repeatedly, you call it as atelectotrauma, and it further damages the lung. So in order to prevent that, you keep a higher P so that it is above the closing capacity. It restores the lung back to the functional residual capacity. So that's very important for you to understand. When you're keeping a higher P in a child with ARDS, you are not trying to hyperinflate the lung. You are just trying to bring the lung back to the FRC so that from there the lung will find it easier to expand. So keeping a higher PEEP will protect the lung from atelectotrauma. And for that part of the lung which is completely collapsed and is not taking part in the oxygenation, recruitment maneuvers may help. So we're not moving on to the recruitment maneuvers because it is a slightly controversial topic there. So other two, definitely. So now coming to what do you mean by optimum PEEP? You should know when you are inflating a balloon. You would have all felt, right? Initially, we find it very difficult to inflate. But after a certain particular point, then the balloon inflation becomes very easier. So that exactly is the lower inflection point of the balloon. That is at a point where the compliance dramatically improves. So this is how a lung also behaves. Initially, you find that it's very difficult to inflate the lung, but after a particular point, the increase in pressure is reflected by an increase in volume, very steep rise. So you are in fact trying to find this PEEP. So if you keep a PEEP somewhere here, you would be getting the best tidal volumes and the best compliance. So this is the aim. Now, how would you know where is your optimum PEEP? So what you normally, so with this, we already said PEEP will prevent collapse, improve compliance, improve oxygenation, and prevent atelectotrauma. So now let us see, how do you do a PEEP? Practically, what do you do? First and foremost, the baby should not be struggling on the ventilator. Give a bolus dose of a sedative or a paralyzed. So because if the patient is breathing, then the compliance will keep on shifting. You will not know exactly what compliance is being delivered. So it's important that the patient is in sync with the ventilator. Then you can start with a PEEP at 6. Some would say a PEEP at 7. There are two ways of doing. Some people go for a decelerating PEEP and some go for an accelerating PEEP. That is, accelerating means from the lowest PEEP, you go up steadily and see which is the optimum PEEP. The other way is you go high, say a 10, 15, and then coming down. In fact, decelerating PEEP is sort of a recruitment maneuver also, because you're already inflating lung to a higher point and then coming back to a point where you're getting the optimum PEEP. So we are not going too much deep into it, just a little bit of basics for day-to-day management. So your aim here is to somehow bring back, if possible, the FiO2 to 60% or less. So now you have sedated or paralyzed the patient. You have set the PEEP at 6 or 7. Then every 2 to 5 minutes, increase the PEEP by 1 or 2. When you increase the PEEP, you look at what is happening to the compliance. Remember, compliance is depicted in the ventilators of its own. You just have to take that page. And also look at the tidal volume, because some ventilators don't depict or don't show compliance. In that case, you can look at the tidal volume. Remember, throughout the procedure, the only maneuver that you are doing is increasing or decreasing the PEEP. No other knob are you touching. So since you are not increasing the PEEP, when you increase the PEEP, there should not be an increase in tidal volume, right? Because PEEP is a thing which does not allow your lung to collapse completely. It is not the one that decides how much air should go in with each breath. So when you're increasing the PEEP, ideally, because the delta P is constant, or the pressure above the PEEP is constant, you should get the same tidal volume. But if by increasing the PEEP, you're finding that the tidal volume is improving, that means either you are opening up new alveoli, or you are bringing the alveoli to the lower inflection point at where the compliance is improving. So a little bit of pressure is giving you a higher volume. So in nutshell, what did I mean? When you increase the PEEP, look at what is the compliance and look at what is the delivered tidal volume. Corresponding vitals and saturation should also be documented. Again, after 2 to 5 minutes, increase the PEEP further. Again, document the compliance, the tidal volume, the saturation, the heart rate, and blood pressure. As you go on doing this serially, you would realize that at one point you get the maximum compliance. And when you increase beyond that, the compliance start decreasing, the tidal volume start decreasing, the patient may show a deterioration of vitals. So at that point where you get the maximum compliance, you take it as the optimum PEEP. So now you have progressively increased and you have found out the PEEP which is giving you the maximum oxygenation. Now, can you keep that? You got a optimum, you have detected a PEEP which is giving you a good saturation. Can you blindly keep that PEEP? Maybe it is say 15, 20. No. Once you have detected the optimum PEEP, you have to again come back to the lung and see whether this PEEP is going to damage my lung or not. So that is not only the PEEP, that is a PEEP and the PIP, everything together. The pressure that I have decided for this baby, is it safe for the lung? Is it protective for the lung? So for that, how would you know it is safe for the lung? So once you have identified the optimum PEEP, you need to check the P plateau. How do you check the P plateau? All ventilators have a maneuver called inspiratory hold. That button, just press it for 0.5 to 3 seconds. Earlier we used to say 3 seconds. Now they say 0.5 seconds is enough. So when you press, you will find that there is a pause, inspiratory hold. That means you are holding the breath in the end of inspiration. And while you hold the breath in the end of inspiration, the air that is there in the airway will go to the alveoli. So the pressure that is being measured by the ventilator is no more really the airway pressure, but the alveolar pressure. So that is what is P plateau. So P plateau is essentially alveolar pressure. Normally, your ventilator measures the mean airway pressure. When you give an inspiratory hold, then the pressure here will fall and will equilibrate with the pressure in the alveoli, and then the ventilator would measure a P plateau. As you can see here in this particular image taken from the graph of McQuay, you can see here that someone has given a inspiratory hold. Inspiratory hold has been active, so there is a pause. So when the pause came, the ventilator itself is showing the P plateau. So that is how you detect the P plateau. So now, having said that, we move on to the next one. That is, once you have detected the P plateau, you also need to know if it is safe or not. So what is the next parameter to say that your ventilator settings are safe? The next parameter is definitely the driving pressures. So what do you mean by the driving pressure? The driving pressure is the difference between the P plateau and the PEEP. So this should be kept less than 15. If it is more than 15, then decrease the tidal volume by 1 ml per kg. So earlier we said, no, if your lung is bad, you need to decrease the tidal volume from 6 ml per kg, you need to come down to 5 ml per kg or 4 ml per kg. So how do you know when do you want to come down? So this is how you decide whether you can still continue with 6 ml per kg or you need to come down on 4 ml per kg or 5 ml per kg. So here at this point, you need to understand that your lung breaks or goes for a pneumothorax when you are hyperinflating it, not because you have not allowed a balloon burst because you have inflated it too much. It does not burst because you did not allow it to empty completely. So that is the basic concept. So it's more than the PEEP, it is the PIP that is damaging to the lung. So that is why you're looking at a lower tidal volume with lower neck pressures. So as an example, this is a beautiful graph published by DNR in their study. And here you can see that they have plotted the PEEP and the P plateau of a child, of a patient with ARDS, adult patient. And initially, when they are starting the recruitment maneuver or the escalating PEEP, the SpO2 is only 79% with a delta P of 15 centimeters. As they go on increasing the PEEP, their saturation slowly increases. So at this point, maybe the PEEP is above 20. They have achieved a saturation of 96. But unfortunately, that is also associated with a very high PEEP plateau of above 35. So if you're only looking at the PEEP, you would have kept at this point, that is keeping a PEEP of around 20 as an optimum PEEP. But since you're also looking at the PEEP plateau and you realize that this would be harmful, what did they do? They have come down one step. So instead of using 25, they have gone back to 20. That is, they have reduced the PEEP to the next one step below. So usually in pediatrics, we are happy doing 1 or 2 times 2 centimeters rise, whereas in adults often they do for 3 to 5 centimeters. So here they have come back to one step below, and at the same time you can see that the delta P from 14 has been decreased to 10 centimeter. From 300 ml tidal volume, they are now targeting 220 ml so that the driving pressure and the P plateau is in the acceptable range, and even then the saturation is maintained. So that is the message. So what did we learn? We learned that after we find out the appropriate PEEP, that is the optimum PEEP, again we need to assess whether that much PEEP is safe for the child by looking at the P plateau as well as by looking at the driving pressures. So let us see what happened to our child. You can see that the optimum PEEP was finally found to be 10, and you have increased the inspiratory time. So now you have a 1:1 IE ratio, and slowly you can also, and the mean airway pressure from 15 or so has now gone up to 18, and which has resulted in improvement in saturation from 61 to 92%. Remember, this does not happen in minutes. It may take hours for you to achieve this. But be patient, do it appropriately, you will achieve it. So that is the aim. So now coming to the next scenario. So we have discussed 2 parts, that is hypoxia during intubation and also hypoxia, progressive hypoxia. So now comes to sudden desaturation. So we all know what you need to do. That is, you rule out DOPE. DOPE is displacement, obstruction, pneumothorax, and equipment failure. But I would say, wait a minute and just see how each one of this you really need to look for. Now, how do you look for display? Well, how do you immediately manage? If a patient is desaturating on a ventilator, the first thing that you do is go disconnect from the ventilator and start your it's not bag and mask, it is bag and tube ventilation. And while you are doing bag and tube ventilation, see whether you are hearing patient sound. Sometimes you can hear the baby crying. So that means your tube has come out. So, or coughing. So that means the tube has come to the glottis, above the glottis. So that you can make out. And after that, immediately you auscultate bilateral to see whether it is equal or unequal. Unequal air entry can be due to pneumothorax or can be tube migration to the right bronchus. So see where the tube was fixed, whether it has gone too much in. If that is not the cause, then pneumothorax is highly possible. Now, when it comes to pneumothorax, you need to know that first thing you should do is, as you're bagging, palpate the chest. If you are able to feel crepitus somewhere, often in the neck, in the anterior chest, that means 99% the hypoxia is due to a pneumothorax. This usually would happen subcutaneous emphysema, especially when you have a mediastinal emphysema, which is commonly associated with a pneumothorax also. Then but if the patient is along with that, or even without that, if you find an asymmetric air entry and the patient is in life-threatening hypoxia, do not wait further. Just go ahead and put a needle in the second intercostal space in the mid-clavicular line, that is with an underwater seal. So needle thoracostomy should be done. Remember, when in doubt, sometimes it's not very clear, you can do a bedside USG. And in the bedside USG, if you are able to see a barcode sign, especially the transition zone, that is one part showing the seashore, which means the normal lung, and one part showing the barcode, you can say that you are dealing with a pneumothorax. But the theory looks very simple, but practically it is not as simple as that. Because sometimes what happens, you have bilateral pneumothorax. So both sides look similar. Then your doubt is whether this is really seashore or are you really looking at barcode. So those kind of confusions can also happen. So if there is asymmetry between the two sides, and in the same side, if you are able to show this transition zone, you are more sure that you're dealing with a pneumothorax. If time permits, definitely a chest X-ray can be taken. But a word of caution regarding chest X-ray, when you have a tension pneumothorax like this, the X-ray would definitely pick it up. But when you have small pneumothorax, that is your lung is very bad and it has just started leaking, and that is the reason why you are having a progressive desaturation, sometimes your X-ray may not pick up. And similarly, when you're putting a needle in the second intercostal space, even when you have a good pneumothorax, sometimes you may not get a bubble coming out, especially when you have bad lungs and adhesions in the pleural space. That can happen. So taking an X-ray is mandatory for every child with a rapid deterioration. So having said that, so that was regarding unequal air entry, pneumothorax, and tube migrating to some side. Now let us see whether the ventilator helps us. So all these were clinical. Now will the ventilator help us to find the clues in cause of hypoxia? Now what do you think? This child, what is the reason why this child is having hypoxia? So soon, while the child is hypoxic, when you go there, this is how the ventilator looks. So what is the reason? So if you look carefully, the pressure scalar looks okay. But when you look at this flow scalar, there's nothing coming down. There is no expiratory limb. A normal flow scalar should look like this. So if you don't have this, that means nothing is coming from the lungs. This is what is going into the lung, supposed to go into the lung, and this is what is coming out from the lung. So if you don't have anything below, that means nothing is going into the lung. And that is again corroborated by your volume scalar. Volume scalar normally should have an upstroke and a downstroke. It's like a sloping stroke. But here, what are you finding? Straight lines. But normally leak, you will have a small straight line. Here, that's a huge straight line. Means there is a huge leak. So you can see here, the inspired tidal volume is 61. The expired tidal volume is only 0.8. So what does that mean? Your tube is out. So it is either a tube out or a circuit disconnect. Maybe something has happened in the circuit. Sometimes happens, the patient moves, or the sister comes, or the technician comes for an X-ray. They have touched something and something has fell off. So if there is some disconnection in the circuit also, you could have these kind of leaks. So this kind of leak means nothing is going inside the patient. So you rule out a tube out displacement and circuit disconnect. Now what about this? So if you see a graph like this in a hypoxic child, what would you do? I'm sure universally most of you are going to say that you will go and suction. I'm happy. That's exactly what you're expected to do. But unfortunately, this patient was given suction, but still his graph was looking like this. If you look a bit more carefully, you would realize that this is a patient who has a PEEP of 4, a set PEEP of 4, and he's getting a delivered PEEP of 10. So what is happening here? So there is an obstruction to his expiration at somewhere. So thinking about that, you have given a suction, so there is no secretions. Then when you look closely, you find that your expiratory tubings are full of water. So this is the reason why you are having that graph. So you remove the water, but unfortunately, even after removing the graph, the graph still remains the same. You look a little more closely, you realize that the water, in fact, is even there at the expiratory filter, the bacterial filter that you have kept. The water is there on top of that. So, and once you remove that also, then you can see how your graphs have become normal. So what did we learn from this particular setup? We learned from this particular thing that whenever the delivered PEEP is more than the set PEEP, always look throughout the expiratory pathway to see if there is any obstruction. That would include your patient may be having a wheeze, there may be a tube block, there may be water in the tubings, there may be water in the expiratory filter, and there may be block in expiratory valve. A word on block in expiratory valve. Whenever you have a patient on a continuous nebulization, remember all the saline. If you have not kept a filter at the expiratory valve, the saline may go and get deposited in the expiratory valve, causing an obstruction to airflow. So whenever you have children with wheeze on continuous nebulization, keep that also in mind as a cause for autopsy. So I think, so that was a learning pearl for us as far as difference in PEEP and hypoxia is considered. So now coming to the next part, that is the tube block. So how do you know there is no tube block? So mostly when you say, did you find out tube block? First time when someone says the patient has desaturated, the first thing that comes to your mind is that maybe there is a tube block. So how do you know there is no tube block? So usual answer is, I gave a suction, I did not find any secretions. Or you may say, I gave a measured suction and I'm sure that the tube has reached, my suction catheter has reached till the end of the ET tube. Or you may say that I did not feel any resistance while I bagged the child. So I'm sure that this patient does not have a tube block. Now let us see one by one what really in practice happens or practically what happens. So if you give a suction and you don't get any secretions, please take my word, 90% of the chance, 90% of times, the chance is the child is having a tube block. Why do I say so? Remember, trachea is not a place where you don't have any secretions. You have secretions there. Your mucosa is there to secrete secretions. So if you're not getting anything, no secretions at all from your trachea, there's a high chance that it is a tube block because of which your suction catheter is not reaching the tracheal mucosa. This would happen when you are, especially when your humidifier is not working. So the moment you get a dry suction, immediately look whether the humidifier is working. And if the humidifier is not working, high chance that the secretions have dried up and caused a tube block. So next time, be aware of that. Now let us take the second one. When you say, I have given a measured suction and it just reached till the end of the ET tube, I'm 100% sure. So now you should know that when you are giving a measured suction, the suction catheter should pass smoothly till the end. There is no obstruction. In fact, if you are not putting a measured suction, it would even go beyond it because your ET tube is typically sitting between T2 and T4. There is ample space below that also. Naturally, you don't want to damage that mucosa by doing a deep suction. But when you say it has just reached till the tip, what really happens is many times I have seen residents trying to put in forcefully the suction catheter and then measure. When you're putting in forcefully, your suction catheter will get bent inside, kinked inside the ET tube, especially if it is smaller in size, and give you a false security that you have reached till here, where in reality, you would not have reached. So think twice before you say, I have given a measured suction. Ensure that it was a smooth flow. Now coming to the third one, that is the commonest one. You say, there is no resistance when I bag. So now you can see our senior resident, Dr. Indira, is bagging. What do you feel? Is there any tube block? Your answer would be no tube block because she's able to bag it so easily. But it is the same person, the same ambu bag, the same ET tube. You ask them to bag again. But now she's finding it very difficult to bag. What happened now? Because she has kept her hand on the safety valve. She's not allowing the air to go out from here. So if there was no block here, the air would have smoothly gone inside. In fact, as you can see here, the ET tube, I've kept a cotton there to emphasize it's a block inside the ET tube, which will not be picked up unless you do an ambu by keeping a hand on the safety valve. So always to know whether there is a block or not, just keep one's hand on the safety valve and gently ambu. That would tell you whether your endotracheal tube is clear or not. Okay. So Now, so that much was for the three explanations of not having a tube block. Now, coming to the next question, does your ventilator tell you anything whether there is a tube block? Yes, the ventilator does tell you. If you find that in a PCV mode, your tidal volume is progressively decreasing, so probably your tube is going on having a block. Or if you are on a PRVC mode or a volume control mode, if you find that your P peak is progressively increasing, that might also be a reason for a tube block. So these are the two clues that the ventilator gives you of tube block. Now, what about this? What do you feel? Why is the graph like this? So I think the comment would be, you would say it's a coupling of breath. Yes, yes, there is a coupling. Then you can say, why is it coupling? So usual coupling reasons is either you have kept a higher rate or a lower tidal volume, but lower inspiratory time. But here you can see the IE ratio is 1:1. So there's no reason why you should say that the inspiratory time is low. But what exactly this was? In fact, it was a tube block. Just after you gave a proper suction, this is how the graph looks. You can see the settings are absolutely, you can see the time 22:47, 23. You can see the settings, they're absolutely same. And you can see the delivered tidal volume has improved to 179, that forcing you to decrease the PIP. So here, what am I trying to say? When you find an abnormal, unexplainable graphic, go and give a section so that you rule out that it is not a tube block that is giving you an abnormal, unreadable graphic. So that is also important. But while I'm telling so much about suction, always remember, give it only when it is needed. When the following clues are there, you give. Don't go on routinely, because especially in an ARDS patient, you would be de-recruiting the lung. What is achieved in hours may be lost in minutes. So that also needs to be kept in mind. Now, does the patient give you a clue that there is a tube block? So as you can see here, this was a patient for whom all the previous things were done. Suction was given, measured suction supposed to be given. And you can see the patient, in fact, is on a tracheostomy, and the verdict was there is no tube block. But look at the patient. What is happening to the patient? The patient definitely work of breathing. But what is it because of an inappropriate ventilator settings, asynchrony in the ventilator? No. When you look here, the depression is happening in the substernal region, suprasternal region, which mainly means that it is your major airway that is getting obstructed. That means high probability that you are having a tube block. A proper suctioning after that, you can see how the patient is after a proper suction, isn't it? Comfortably sleeping, no retractions, and the savior is there beside him at the bedside. Okay. So that is an important point for you to learn, that whenever you find a patient's work of breathing causing a substernal or suprasternal retractions, always think of a tube block. So what was the learning pearls in tube block? No secretions may indicate tube block and malfunctioning of humidifier. Bag and tube ventilation with safety valve closed will only tell you whether there is a block inside the tube or not. A low tidal volume and a high P peak may indicate tube block, and a patient with increased work of breathing, especially suprasternal and substernal retractions, indicate that you have a tube block. Now, last but not the least, equipment failure. So that's one of the commonest favorite answers that often the residents like. Every time something goes wrong, you feel you have a tendency to say that ventilator is not working, it is not delivering. The moment I am connecting the patient to the ventilator, my patient is desaturating. But before you say that, think twice. What you need to know, that it's rarely, very, very rarely, equipment is the fault. It's usually us. We are the ones, or our patients are the ones which are responsible for the hypoxia. So how do you know the equipment is not at fault? Just disconnect the patient from the ventilator, connect to the ventilator tubings to the test lung, and see what is happening. So once you have connected the test lung to the ventilator tubings, and if the graphs are okay and the tidal volumes are delivered normally, definitely your ventilator is not at fault. So if when you are connecting to the test lung and still the abnormality is persisting, that means something is wrong with the ventilator. So always check that before telling that it is a equipment failure. So what did we learn today? We learned that pre-oxygenation before intubation is for removal of nitrogen. We also learned the importance of apneic oxygenation during intubation and how it reaches your blood. We also learned that NIV delivered through nasal mask may limit de-recruitment during intubation, and just finding the optimum PEEP is not enough. You need to have an eye on PEEP plateau as well as driving pressures. And your ventilator graphics may help you in many of the difficult situations. So hope it was useful for you. Thank you. So that is for today. I hope it was useful.